Good morning and good afternoon to some of you. My name is Savia Tucker. Welcome to Hopkins at Home. I'm an orthopedic surgeon focused on hip and knee arthroplasty, and I work at Johns Hopkins, predominantly at the Howard County General Hospital. Today, I'm going to be presenting on robotic total joint arthroplasty, specifically total knee and total hip arthroplasty. And I ask a question: is this the technology of the future? Or is there something better, something different to help our patients with hip and knee conditions? My disclosures that are relevant to this talk are none, but I wanted to start off by presenting a little bit about the history of Johns Hopkins. If you've trained here, or you've worked here, or you've been a patient here, you can familiarize yourself with this building, which is the Billings building, which is the main Johns Hopkins building, or the dome. Now, what's interesting is that when this dome was built initially in the 1900s, there was no place for patients and their family members to come and pray. Johns Hopkins himself was a Quaker and did not believe in any form of idol worship. So what happened was that as patients came to this hospital, as the complexities that this hospital tried to resolve and tried to help patients with increased, patients required some source of spiritual guidance, some source of a monument, to say, where they could come and pray and they could come and bring their beliefs and to try and improve their own health or their family members. So what happened was that there was this statue of Jesus Christ shown here on the right, which was installed. But there was a problem. When the building was built, the doors were not wide enough to bring this monolithic statue made out of marble all the way into the building. So they had to actually take apart the dome and lower the statue by the help of a crane. And at that point in the 1900s, this was considered to be advanced technology. Where are we today? Well, this is the view not a very long time ago when I was graduating from Johns Hopkins with my orthopedic residency. And it's just a different perspective as to where things are today compared to where things were in the 1900s. So for all of you that have walked through the dome and have enjoyed being at Hopkins, here's an interesting perspective on where things are today. Now, when it comes to arthroplasty, the goals of arthroplasty are twofold, and this is for joint replacements. The first goal is a technical goal, which is what we as healthcare providers and surgeons are most interested in. The second goal is the patient-specific or patient-oriented goal. What are goals that patients come to us with regards to their hips and knees? And how can we help reconcile the technical goals and the patient-oriented goals? So from a patient's perspective, what they're looking at is to have a stable, functional, and a relatively pain-free hip or knee or any other joint that they're seeing an orthopedic specialist for. When it comes to surgeons, we prefer to really look at things in terms of the technical aspect of it. And I'm going to show you a few videos that illustrate this concept. This is a video of a knee going through various degrees of motion as you bend and you straighten that knee. And please observe that there are various degrees of sliding, rotation, pivoting associated with the knee. And this is an example of a total knee prosthesis that I or one of my colleagues would implant in a patient that has knee arthritis. So we need to make sure that we're very precise in restoring the kinematics, meaning how the knee functions during load-bearing settings. The other thing we need to think about is how to achieve balance in a joint. So this is a video that's going to demonstrate how various technologies are used in our day-to-day setting in trying to achieve balance between the inside of the knee and the outside of the knee. This is a sensor-assisted platform, and this is a smart sensor. There are various different shapes and sizes from various different companies. And now we have a real-time idea of how balanced that knee is. If there is too much balance on one side, we can perform very specific and very precise releases in the soft tissues or the ligaments that control your knee to try and achieve a better balance, with the hope that patients would achieve a more functional long-term outcome. And what we're interested in as surgeons and healthcare providers is to ensure longevity, whether it comes to your joints, whether it comes to your health, whether it comes to your life. So we want to try and preserve that longevity, and we want to try and give you the sense of balance, the sense of kinematics, the sense of activities. And we need to be able to reconcile the patient-oriented goals and the surgical goals of these procedures. So that's when a lot of technological or technical advances into the field of orthopedics really came into play. There are really two types, and I'm going to be spending most of my time on robotics, but the precursor to having a robot in the operating room was a device that looked like a GPS in your car or on your phone, and that was navigation. So what's the goal of navigation and of robotics? Well, for me as a surgeon, it should be reproducible, it should be easy, and it should really help improve our outcomes from a relatively poor or fair quality to a great quality of outcomes if we're going to invest in using a robot or any surgical advancement. When you talk about robots, it's important to make an analogy to cars, because a lot of our robotic systems can be related to cars and how things have evolved in the cars. So the first type of robot that we have is a semi-autonomous robot. And I'm going to play a video of a Volvo, which involves this technology. So this is called the pilot assist feature on the current generation of Volvos. And what that entails doing, and I'm going to scroll ahead, at the click of a button, what the car will do is that it will sense a car ahead of it. It will also sense whether you're staying in your lane. And if the car ahead of you slows down, this car will automatically slow down. If you stray from one lane to another, it will give you a vibration on your steering wheel, a vibratory sense, so that you correct your course. Now, the assumption is that the driver is still paying attention and the driver is still driving the car, but the car is making some decisions for you to assist you. And especially in a situation like this where you're caught in a traffic jam and you really don't want to pay too much attention, or you're really going to get fatigued putting your foot on and off the accelerator, the car can automate some of those functions for you, provided that you're providing some guidance to the actual car. In contrast, let's look at a Tesla. And this is a very fascinating video in which a driver is starting off at one of the Tesla offices and programming the Tesla to drive itself. So here you see that the driver is not using any of his appendages, not using his arms or legs to control the car. The car is making almost automatic decisions and autonomous decisions on various things like entering the freeway, making sure that it can catch up to the speed of the other cars on the freeway, and then slowing down, exiting off the freeway, maintaining guidance of the various different road signs that you need, and then gradually bringing it back to its destination. And this is a scary thought because the driver is not doing anything. So it takes a little bit getting used to where you're letting the car make all these decisions and letting it drive for you. Surgical robots can behave in the same way. You have semi-autonomous robots in which surgeons can maintain some form of autonomy and delegate some of the more mundane tasks to the robot. And you have autonomous robots in which you can calculate a very precise plan, dial that plan into the robot, and then the robot takes over. You do have the option of stopping the robot if you see that there is some issue with the plan that's being executed. But overall, the robot can control a lot of the decisions for you. So let's kind of move into various different examples of robotic systems. The earliest orthopedic robot was this device called RoboDoc, and it is now known as Think Surgical. In Think Surgical robots or RoboDoc robots, that's an autonomous robot. You obtain a CT scan in addition to some imaging from a patient, some x-rays and a CT scan. You take all that information and plan that using the OrthoDoc planning station, a workstation that lets you achieve a very precise plan. You then feed the information, including a CT scan and your surgical plan, into the robotic arm. And the robotic arm at certain points during the procedure takes over and makes very precise decisions and helps shape the bone for the implant. So let me show you an example of how a total hip replacement can be done using the Think Surgical robot. I'm going to scroll a little bit ahead. So this is our planning software that we can use. Once you take that information from a planning software, in the past we would do this with a CD-ROM, but now you can do this off of the cloud. It gets placed into the robot. As a surgeon, I make sure that I position my patient, I clean their skin, I go ahead and make the surgical exposure to their hip. So here I am making a surgical exposure to the hip. And then we go ahead and we place certain landmarks or certain ways that the robot can understand that now we want the robot to speak to the bone, if you may. Once these landmarks or arrays are placed onto the bone, I can take a device that looks like a pen and map out the very precise anatomy that comes with each and every patient. So the robot gives me these targets that I have to hit with a pen. And once the robot is satisfied that the targets that it has placed on the basis of a CT scan matches the targets that I acquire using my registration, then the robotic arm comes in. And at this point, the robotic arm is completely automatic, and it creates a very fine cavity for us to go ahead and place an implant into someone's thigh bone and give them a hip replacement. Now, of course, if I did not agree with the plan, I could stop the robot. But for the most part, the robot behaves autonomously. An extension of this also happens in total knees. So a similar robot, we use the planning software, and I'm going to scroll ahead in the video to show you this. So this is the planning software in which I can look at the patient's bone based off of the CT scan and then plan where the implant is going to sit. We now take that plan into the robotic system. So this is the plan. I'm going to scroll a little bit ahead as well. And here's the CT scan that you can work with. So we take this, we can adjust very precisely how we want to position the various different components that we will be using, in this case for a total knee replacement. We feed that into the robot. And once again, the surgeon makes the exposure for the robot. So we get inside the knee. And once again, we assemble our arrays that enable us to talk to the robot. And then the robot gives us a device that looks like a pen and asks me as the surgeon to map out the very precise anatomy that exists in a certain patient. The robot then takes that information and compares that to the CT scan and the plan, which we've already fed in, and then brings its robotic arm with very precise control, goes ahead and shaves parts of that bone so that we can go ahead and put the implant. Now, the placement of the implant still depends on the surgeon. The robot does not help us do that, but at least some of the other steps of the surgery can be assigned or delegated to the robot. The next is the Mako, and Mako is devised by a company called Stryker, and that's probably the most famous robotic platform that is out there. And a lot of patients really know about this and ask for this specific type of robot. A Mako is basically a semi-autonomous robot. So it's not a Tesla, it's more like a Volvo. And what it does is that, again, using a very precise CT scan, it helps achieve very precise resections within the patient. So now you take a CT scan and you have a robotic arm that's like your robotic assistant that is there to help you. Let me scroll a little bit ahead. This is the planning software, which allows us to plan in 3 dimensions on how we want to place certain components when we're doing our surgeries. Again, the robot gives us these landmarks that we have to achieve, that we have to hit, so that the robot can compare it with the CT scan and say that, yes, this is very precise. Now, then we introduce our instruments into a patient. And if we waver from the path that the robot has predetermined for us, the robot will stop functioning. But here you can see that the robot has created this green template. And once you go ahead and you finish the procedure, that green becomes a color white. If you deviate and it becomes red, then the robotic arm basically stops you in its tracks and does not let you proceed unless you manually override it. So there is a manual override function, but for the most part, you can control, or the robotic arm helps you control your arm very precisely while doing the procedure. Now, Mako is not only good for total hips, it's also emerging to be very good for total knees. So here is an example of the Mako platform for total knees. And let me again scroll ahead so that you can actually see how the robot functions. You again have a plan that you can help patients achieve their anatomic balance and restore their anatomy and restore their kinematics. You then take the plan and the robot tells you to map out certain landmarks on various different features of the bone. And once you've done that, you can go ahead and state that this is going to be the final implant for the patient. And here's an example of us using a saw where the robot has drawn out a plan, and I'm taking the green area and making it completely white. So making very precise resections with a robotic arm controlling me so that my arm doesn't slip or falter. In addition to total knees and total hips, the Mako is also good for a partial knee, which is called a unicondylar knee replacement, or a UKA. Same principle. Once again, you have a robotic arm, and I'm going to try and again scroll ahead to see how this robotic arm functions. So at this time, instead of a saw or instead of a burr, instead of a reamer, you're using a device called a burr. And what the burr lets us do, once again, when we get into a patient, here's the plan. And now we're going to burr out, we're going to shave off certain parts of that bone, which are green. And we will go ahead and make it a nice smooth surface for a partial knee replacement implant. So here comes the burr. And if you deviate from the plan of the burr basically just stops in its tracks and does not let you deviate. So here's that very, very precise resection or shaving down of bone, which we can do from a very small approach to make it convenient for patients to heal from their procedure. Now, those were two examples of robotic systems. There are more systems. Here is an example of a hybrid system, which does not involve using a CT scan. This system relies on the patient's intraoperative anatomic features. This is called the Navio system, in which you can perform real-time planning once you've mapped out the patient's anatomy. So this is a bridge between surgical navigation and robotics. Remember, I mentioned to you that navigation is like a GPS. So here is our plan. Here's our route map that the navigation device gives us and allows us to very precisely map out the route that we want to take during this procedure. Once again, you have an example of a burr. In this case, instead of the burr stopping in its tracks, the burr tends to retract like a turtle into its shell if you're deviating from the path. So this type of technology works, again, really well, really precise through very little incisions. The good thing that's associated with this technology is that you do not have to get any imaging done before surgery except for an X-ray, and you can rely predominantly on intraoperative landmarks or landmarks that are achieved during the procedure to make very precise resections. The Navio is not only good for partial knee replacements or unicondylar knee replacements, it is also emerging to be a very good tool for total knee replacements. Again, using the same retractable burr type technology. Here is the planning module, which we can plan in real time during surgery for a patient. And then we go ahead and we can take that burr and we can achieve very, very precise assessments or very precise placement of our cutting blocks. Once we do that, we can make very, very precise bone cuts into the thigh bone and into the leg bone to give patients a brand new knee replacement. Moving along, here is an example of a robotic system that's probably the newest on the market. This is called the ROSA system. The ROSA system, again, achieves intraoperative landmarks. It allows surgeons to make intraoperative decisions with regards to a plan. It doesn't really require a CT scan for the patients, but you can achieve intraoperative landmarks. And then the robot brings an arm and it positions that arm in space, and it does not let you move that arm once it's within its field of view. And then you can go ahead and make very precise cuts. So you as the surgeon are only using that arm as a very stable and a very reliable assistant to hold things for you so that you can go ahead and do your surgery. Again, an example of a semi-autonomous robot. And as the leg moves, the robot does not lose sight of that leg and it moves the arm with the leg. But you yourself as a surgeon are going to find it very challenging to move that arm if you're not facile with the nuances of that robot. And finally, this is an example of a robotic arm that you pin onto a patient. And again, it moves the arm three-dimensionally in space to try and achieve a very precise bone cut. So another example of a semi-autonomous robot, and another example of how we can bridge navigation and robotic technology. Now, this is only good for total knees. So once again, you map out the anatomy in the knee. You do not require a CT scan. And once you've mapped out the anatomy and created the plan, and I'm going to scroll forward, this is the plan that you've created on the field. You can go ahead and fix this robotic arm. And now you can see this robotic arm moving from side to side, from area of the bone to another area of the bone, allowing the surgeon to bring a device called a saw to make very precise bone cuts. And again, the robotic arm is not going to move in space, so it's going to allow you to have very precise control. Well, these are various different examples of robotic systems that we have in orthopedics and specifically in joint replacement surgery today. So how do these do? These technical advances and technological advances are not foolproof. They do have some limitations associated with them. For the most part, we've studied this in the literature, and we've studied various different robotic technologies here at Johns Hopkins. We've found that for the most part, these are very accurate, reproducible tools. So at least it's achieved some of its goals that it initially had set out. Patients seem to recover very nicely from these procedures. From the patient perspective, very rarely are these damaging to the patient's anatomy, assuming, of course, the surgeon knows how to use these technological advances. However, in terms of the outcomes, there is very limited outcomes data that exists till date, and these are very expensive technologies that definitely add cost, it adds time, and it adds a certain amount of a learning curve and an expertise that one needs to achieve in order to be comfortable with these procedures. With that being said, I thank you very much for your attention, and I invite any questions that you may have. So I have a question from Kathy. Are bilateral total knee replacements now very common? The answer to that is yes. Bilateral knee replacements and bilateral hip replacements are done for patients that have arthritis on both hips or both knees. There are several ways of doing this. You can do this either simultaneously or you can stage them, meaning that you move them apart by a certain number of weeks. A large part of the discussion really has to happen with how bad the condition is for each individual patient and how long the recovery period is going to be after this procedure. Typically, patients need about 6 to 8 weeks of physical therapy to recover from these procedures. So if they're willing to invest that amount of time into their care, we can certainly make bilateral total joint replacements a reality for them. I also have a question from Trisha. How do you decide which robotic approach is best? For the most part, these robotic systems have an equivalent amount of outcomes, meaning that they are equally precise and they're equally exact in which type of surgery you want to perform and what type of outcome you want to achieve. However, that being said, certain robotic systems are tied to certain implant systems. So the surgeon has to be careful that they use a robotic system that gels well with the implant system of their choice. And that's a discussion that you should have with your surgeon in the office. I then have a question from Margarita. Why would you not want to do a CT scan if you could? Well, that's a fantastic question, Margarita. So CT scans, they offer three-dimensional pictures of someone's anatomy, but they do involve cost and radiation associated with them. The CT scan result is definitely more precise, but it's important that you compare the result of the CT scan with intraoperative landmarks, because between when the CT scan was observed and when the surgery actually undergoes, there may be some changes in the bony architecture. So it's imperative that the surgeon controls for that while doing the procedure. And that's why in some cases, you may ask, well, then why do you get a CT scan when there's going to be an alteration in the anatomy? And that's why each of these robotic systems has a fail-safe mechanism allowing the surgeon to obtain intraoperative landmarks and compare that with a CT scan before moving through the surgical steps. We also have a question from Adam. Can you talk more about the RoboDoc and why it is not used? The RoboDoc was an earlier generation device. Now it's been rebranded as a Think Surgical device, and a lot of places are using the device. It is definitely a very precise robotic system in use today. The problem with the RoboDoc is that it's not a multi-platform system, meaning that for now, it's only been associated with total hips and total knees. We don't have a platform for partial knee replacements, and that's why the uptake on that has been a little bit slower. Also, it's a more expensive device. The good part about it is that it has not traditionally been tied down to an implant company. So it's a more open platform device, which makes it more flexible for surgeons to use with. Here's another question from B. I'm sorry if I'm mispronouncing your name. Are robotics also used for partial hip replacements? And the second part of this question, any looking forward to shoulders, ankles, and hands? That's a great question. So partial hip replacements, the only robotic system out there that can be used for partial hips is probably going to be the Think Surgical, in which you're really doing a very precise milling, if you may, of the thigh bone or the femoral bone. So you can apply that to a partial hip replacement. The other robotic systems are really not that good for that specific procedure. Partial hips are typically reserved for less active patients that have undergone the procedure because of a hip fracture. So for the more active functional patient, you're really going to perform a total hip replacement. Now, when it comes to shoulders and ankles and hands, we do not have robotic systems at the moment for ankles and hands. Things for the shoulder are on the horizon. And of course, the shoulder is kind of the next generation of joint replacements that is gaining a lot of traction. In terms of radiation risk, because I think that's what you also asked, CT scans do involve a radiation risk when you're getting the procedure performed, the CT scan, but the actual robotic device does not add any CT scan to your surgery. So here's a question from Sue. Why only limited outcomes data? And how long have these devices been around, and aren't patients surveyed intensely? So that's a great question, Sue. These devices, for the most part, have been around in the clinical field for about the last 10 or 15 years. So we only have device data for the last 10 or 15 years. And that's limited compared to the actual duration these surgeries have been performed, which is over 30 or 40 years. So that's why when you look at how long the surgery is being performed, that's for about 30 or 40 years. But the devices themselves, the robotic systems, have been about 10 or 15 years. So about 1/3 less data than you would get from the actual procedure. Now, the patients are surveyed very intensely, both before, during, and after surgery to try and account for that. The other good news is that we do have better measurement tools now, and patients are more responsive with regards to patient-reported outcomes and telling us. So I think that this data is going to grow. We just have to give it a little bit more time. From Jennifer, for someone with hip osteoporosis, will this technique work? Absolutely. Hip osteoporosis or any kind of osteoporosis involves weakening of the quality of bone, where the bone is soft, it's porous, and it has more spaces between it. A robotic system does work with that. However, some of those guides that we apply to the bone have to be very carefully placed so as to not fracture the bone. But osteoporosis does not preclude you or does not prevent you from undergoing robotic guided surgery. Here's a question from Stefano. Is there any system that can provide support for both spine procedures and joint replacements? That's an excellent question, Stefano. So as we are growing this technology, we do realize that there is a spinal pelvic balance, especially when it comes to total hips, that is growing onto total knees as well. At this point, we do not have commercially available technology that's going to work on both the spine and the hip using the same platform. There is a device called BrainLab in which you can navigate both the spine and the hip at the same time, but a robotic application of that is on the horizon, but we do not have that clinically available to most surgeons as yet. We now have a question from Patty. Which one or system are we using at Hopkins, and how are outcome data being obtained for comparison purposes? That's an excellent question. So at Hopkins, we're trying to use various different devices and trying to use various different systems. I would say by far, the one that we are getting more comfortable with is the Navio device. Outcome data are, we're obtaining that in real time, like I said, with patient-reported outcomes. We're looking at imaging quality both before and after surgery. We're looking at patient follow-up in the short term and the long term. And we're not only matching the imaging, we're also matching that with actual patient-reported outcomes. We're trying to use computer-assisted data collection. We're using various databases to try and augment what we know about patients and what we know about these implants. So there are various different modalities used to collect these outcomes. Here's another question, probably from the same person, Kathy. Are there differences in patient-reported pain management using robotic techniques? Till date, no. From the patient's perspective, in terms of pain management, the robotic system hasn't been completely successful at removing pain completely from the surgical procedure. So yes, in some robotic systems, we do use smaller incisions, and that may lead to less pain overall. But pain scores, whether or not we use a robot, is not very clearly beneficial towards using that robotic technology. Here's a question from Garen, and building on Kathy's question. Why would you stage a procedure if you're performing bilateral total knee replacements? That's an excellent question, Garen. So, I liken a bilateral procedure, or any surgical procedure for that matter, to flying an airplane. For most of us, if you put us in a cockpit in an airplane, we can keep that airplane in the air. And I'm sorry if I'm offending any pilots, but with detailed instructions, probably from ground air traffic control, we could try and keep that plane in the air. The hard part for novice pilots or pilots in training is to take off and land. The hard part during surgery is the anesthesia part, which is going under anesthesia and coming out of anesthesia. So what you want to try and do is you want to try and minimize those occurrences. However, sometimes during anesthesia, your heart or your lungs or your other body organs may not perform as they should. And in that case, we would need to stage the procedure. Also, by doing two procedures at the same time, patients can have more pain, and there are more complications associated with them. There's a higher blood loss. There's a higher chance of infection sometimes. So you have to be cognizant of these complications and of these risks, and then counsel patients and make your decisions from there on out. Here's a question from Lonnie. Is the recovery or therapy time any different for robotic approaches versus traditional methods? For the most part, Lonnie, the recovery time is not very different. However, I think that it's because we do not have sensitive tools to really map out how precisely these implants are being placed in patients using a robotic system. We are only relying on CT scans and on X-rays, and it's impossible to keep getting so much imaging post-operatively because these implants also interfere with the kind of imaging that you get post-operatively. So I think that as the tools develop to understand how we place these devices, we are going to see that there is going to be some advantage to the recovery and therapy time by shortening that for patients. At the moment, though, they're very similar. So here's a question from Russ. What are the percentage of hip and knee replacements currently using robotic systems in the US and at leading medical centers? Russ, I mean, I think that's a great question. At Hopkins, we have access to various different technologies that we're studying. I had also performed a part of my training at NYU where we had every single robotic system for us to work with. For the most part, I would say that about 20 or 30% of hip and knee replacements are being performed using robotic or any kind of technological advance. But as we move forward and as these systems become more open platform, as they become more economically viable, I think that the surgeon is going to be inclined more and more to use them. Now, you asked about leading medical centers. Leading medical centers are usually academic medical centers that are doing a lot of research and also seeing a more complex variety of patients. So in that situation, it's almost a selection bias where we're also seeing problems that emanate from these systems, making the usage of these systems a lot more cautious. So there has to be a fine line between how quickly you adapt to technology and how long you should wait for problems in that technology to emerge before you recalibrate and try and achieve a better outcome for patients. From Adam. What are the pitfalls or concerns related to the use of robotics? And why do surgeons not use these autonomous robots more? Is there a big difference between ROSA and Think Surgical? Fantastic questions, Adam. So there are a lot of pitfalls associated with them. The devices that we use to place the trackers onto the bone can potentially break around that. The robotic plan or the surgical plan may not be accurate. And if the robot went rogue, and you as the surgeon did not recognize in time, you would have to then work on fixing that plan, and you would have to work intraoperatively to try and achieve a better plan for the patient, because you cannot send a patient out with an outcome that is less than optimal. So those are problems. Autonomous robots like the Tesla car do have some problems associated with them as well. You've seen in the news reports of people getting into crashes if they're still not paying attention to the road. So as surgeons, we have to pay attention to what's going on during surgery. And as time passes, I think that we may be more comfortable in delegating certain tasks to the autonomous robot. But for the moment, the Think Surgical is the only autonomous robotic software that's out there. Everything else is semi-autonomous because we have to be very cautious in how we adapt and how we adopt this technology. And the big difference between Think Surgical and ROSA is that ROSA achieves autonomy only after the surgeon has cleared the plan. And again, it's a semi-autonomous structure because it does not go ahead and perform the precise bone resections, but it places certain parts of the resection guides for surgeons to go ahead and perform that. Now, the other difference is that the ROSA is the newest entrant on the market, and it is only limited to total knee replacements, whereas Think Surgical can be used for hips and knee replacements. So Edward asked a question, would you elaborate on the last bullet of my final slide, which is radiation? Edward, the radiation risk that we're talking about predominantly relates to the CT scan that needs to be obtained for certain procedures or for certain robotic systems, whereas most other robotic systems do not require a CT scan. So if that's the case, Not only are we getting x-rays for patients, but we're also adding radiation risk by getting a CT scan of the entire leg for the robot to go ahead and plan some steps of the surgical procedure. Here's a question from Eric. How has the medical training adapted to accommodate for these new technologies? Eric, that's a fantastic question. Medical technology and medical training have to kind of work at a synonymous pace in some ways so that we train the leaders in medicine or the future leaders in medicine to be comfortable with these technologies. So, of course, I have residents and fellows that work with me, and when they work with me, they get to plan the surgeries with me, they get to execute some of these surgeries, they get to plan some of the robotic steps so that we are teaching them how to adapt and how to use this. Certain companies like the Mako also offer more training programs for surgeons to come and visit various different centers and learn from surgeons that are experts in this field. So as a surgeon, I think that the best part for using this technology is to learn from your peers, to understand the limitations of the technology that you have at your disposal, and to also understand the potential benefit from it. So I think as a peer group, we're definitely stronger when we're teaching each other. From Stacy, does the robotic system require more or less time in the operating room and more or fewer blood transfusions? Also, fewer complications and recovery time potentially? Stacy, so on average, when we've looked at this, the robotic systems, no matter what system you use, initially adds about 15 minutes to 30 minutes longer in the operating room. Now, that may not sound like much, but keeping someone's knee or hip open for 15 or 30 minutes longer does increase the risk of infection, does increase the risk of anesthesia, and does increase the risk of blood loss if you're operating around critical structures. So that does happen. However, with passing time, as you become more comfortable using the devices, as you become comfortable reading the information that the device is relaying to you, then that learning curve does become shorter and shorter. And now, I think if you're comfortable using a device, it may not add more than 5 or 7 minutes to your surgical time. And the hope is that it will also help reduce complications and improve recovery time as we get more and more comfortable and as more devices get used. I believe that those are the only questions that we have on there. Oh no, there's one more question from Lonnie. Do you need to live in the general area of a facility with these tools to have the robotic procedure? I'm guessing that you are alluding to how close you live to a center that offers them. For the most part, no. I mean, I think that a lot of centers across the country are offering them. So if there is one in your vicinity, I welcome you to have a discussion with your surgeon on which robotic system they have, what is their experience with them, what are their outcomes with them. I think that it would be challenging for any of us to say that we have 100% success with these procedures. There are always some issues that are encountered in any surgical procedure. So just be frank in your discussion with your surgeon and hope and expect that the surgeon is being frank in their discussion with you. And what's the length of post-operative stay for a typical case? So Lonnie, that's an excellent question. For the most part now, and I think that COVID has helped us achieve that, we are trying to send patients home the same day of the surgery if they qualify, meaning that if they have good health, if they have access to a coach or a family member or a friend at home that can help care for them, if they have access to facility, and if they feel comfortable that their pain control is adequate. So for most points, we can get patients home the same day with or without these technical advances. And then this is the one question from Claire. What advice would you give a medical student who's considering a career in orthopedics? And how did you decide to take this path? Claire, that's an excellent question. It requires, I think, probably another talk, but orthopedics, for the most part, My father was an orthopedic surgeon in India. I was born and raised in India, so it was a very personal connection. I think I grew up seeing him and seeing what he did for his patients. For myself, I like patients to get better quickly, to restore their mobility as quickly and as effectively and efficiently as possible. And that's what attracted me to orthopedics. I'm also kind of an engineer when it comes to thinking about concepts and applying concepts to the human body. So that was a natural transition. And in terms of a medical student who's considering a career in orthopedics, I think it's a very rewarding career. I think that you should, if you're a medical student asking me this question, you should definitely do several rotations in orthopedics at your home institution and try and travel to other institutions, which I understand now is restricted, but at least do a virtual rotation in other institutions to understand the rewards and also the challenges associated with this field. But if I had to go back and do this once again, I would, once again, love to become an orthopedic surgeon. Thank you very much. Once again, from the chat box, I'm told that this is the last question that we have. It was great to have all these questions, to engage all of you with this discussion. I'm very happy that we can offer these technical and technological advances to our patients. And there's a lot more that's going to emanate from this field. And I welcome you to come and see us and have discussions with us on how to improve your hip and your knee care and other facets of your healthcare in general. Thank you, and wishing you a very happy and healthy holiday season.